Welcome back, everyone. It's really great to be with you again. I have the honor and the pleasure of welcoming two terrific guests who are leaders in the industry. Michael Lee, Dr. Michael Lee, is Executive Director and Medical Director in the Department of Accountable Care and Clinical Integration at Boston Children's Hospital. And Alex Koster is Director of VBSO Analytics and Technology at Nemours Children's Health. Welcome, both of you.
Good morning. Happy to be here. Thank you for having me.
Yeah, thank you.
Absolutely. So before we plunge into our discussion, let me just have each of you describe yourself a little bit and your role in your organization. Why don't we start with you, Dr. Lee, and then we'll go to Alex Koster.
Sure. So I'm a general pediatrician, and I'm running this Department of Accountable Care and Clinical Integration at Boston Children's Hospital. And what we do is look at the financial and clinical quality performance of contracts that link our primary care practices, our specialists at the hospital under the Physicians Organization and Boston Children's Hospital as a single unit. And we have contracts through Medicaid and commercial contracts that do that. And then in addition, we work on improving the patterns of care that can improve the performance in those contracts. So that's what our department does.
Wonderful. And tell us a little bit about your network.
So our network is pretty large. We take care of just about 20% of the children in Massachusetts. So we have about 400,000 children in our network. And about a third of them are in risk-based contracts that are managed through my department. We have 85 practices in the Pediatric Physicians Organization at Children's, which is the clinical practices that are spread throughout the entire state. And then our physicians organization is the specialists linked to Boston Children's Hospital. And then Boston Children's Hospital is, as you know, a large academic teaching hospital in Boston.
Great. And about how many primary care physicians and how many specialists altogether?
So there are just under 400 physicians. There's a few dozen practicing advanced practitioners, nurse practitioners, and others through our network as well. I don't actually know the number of specialists throughout Boston Children's, but it's a lot.
Okay, great,
across every specialty.
Great. And 400 is a large network in pediatrics. So
yes,
yeah, absolutely. Alex, tell us a little bit about your role in your team and tell the audience just a tiny bit about Nemours Children's Health if they don't know about it.
Sure. So I'll start with our health system. We are a large multi-state pediatric health system. We have a hospital in Wilmington, Delaware, and a hospital in Orlando, and about 80 specialty and primary care clinics in Delaware, Pennsylvania, New Jersey, Florida, and a small footprint in Georgia. So it's a little bit of an interesting geography. I'm part of the Value-Based Services Organization, which was created around 4 years ago to really help in our transformation to value-based care, alternative payment models, and also to align different population health kind of teams and efforts that we had around the common goal. Both obviously success in those new alternative payment models, but also really driving the population health and improved care and prevention for our children. Much of my focus is really in our Delaware Valley practice, which has about 20 primary care clinics, as well as over a dozen practices that are part of our children's clinically integrated network. But I also support our primary care operation in Florida from a kind of technology infrastructure and analytics perspective, which is an additional 19, I think, clinics near Orlando.
Great. And about how many physicians is that altogether?
Well, Nemours is a health system, employs somewhere near just south of or around 1,000 specialists, primary care doctors, psychologists, and other. I guess we have the same a few dozen who are the advanced practice nurse or physician assistants. Our primary care operation, I don't recall exactly how many physicians it includes, but it's a number I ought to have handy, so I'm definitely going to learn that one.
Okay, great.
It's in the low hundreds, I believe, in terms of primary care. We have about, in our primary care operation in Delaware, Pennsylvania, it's about 120,000 children plus another 50 some odd thousand for the clinically integrated network. And then our Florida operations about another 74,000 children.
Great. Thank you so much, both of you. I'm just going to very briefly ask each of you to describe some of the core things that you're working on right now in terms of analytics to support population health. Why don't I go with you first, Alex, and then you, Dr. Lee.
Well, so my team is kind of has their fingers in a lot of different places. We're working right now on integration of our new school-based clinics and the flow of data so that we can actually look at the prevention activities that come out of the school-based programs and also volume reporting, and then link them back to some of the data sets that the school wants us to provide data on. Outcomes, behavioral referrals, things like that. So that's one of our projects. We have another project to look at high absenteeism students and receive alerts about them so that we can deliver some care coordination activities and see if they need clinical follow-up. We're working on implementing both the EMR integration for our new care management system and the analytics for that, so that we can do both management level productivity reporting for the care management team, as well as individual patient tracking and outcomes tracking and things like that. Claims data integration with a few payers. And right now, one of the things we're looking at is, this is typically prevention season where we do a lot of outreach to get through well visits due by year end and then flu outreach. And that, for the first time, it's really hitting this off-cycle sick season that started because of COVID and the huge resurgence in respiratory infections and other viral illness. So we're trying to help our operations kind of customers navigate what levers can we push to manage our prevention while also addressing a huge increase in sick visits and some challenges with staffing.
Great. Thank you. Dr. Lee, what are some of the areas that you've been working on with your team?
Everything Alex said. No,
okay.
I think, he at the end there highlighted some things that we're all struggling with right now, which is the resurgence of volume in a very substantial way, evolving through this stage of the COVID pandemic, which is really fascinating and challenging for both the primary care docs and the hospital. I think what we're working on, so we spent a good deal of time over the last 4 to 5 years, really working on understanding our network and really understanding patterns of care. So we've spent a lot of time looking at children with medical complexity and trying to figure out which subsets of kids have which types of patterns of care. And the reason for that in a cost and quality performance network is that we track our preventive services extremely well across the network, and in general perform extremely well. Massachusetts is a fully insured state. We have generally reasonably good access in primary care. We are focused on comparing interventions right now between kids who are, say, on Medicaid and kids who are commercially insured. We are trying to focus more on the race and ethnicity gaps that we see in our network. To narrow those gaps and improve the performance. But generally, we have pretty good performance in our primary care setting for pretty much all preventive measures. We have implemented extensive integrated behavioral health systems. So we've worked on understanding the impact of that. Last year alone, we did over 40,000 behavioral health visits in our primary care network, which would have been unheard of 5 years ago. So trying to understand the impact that while we are still not really touching the high acuity kids in that space who are somewhat overwhelming our system in Massachusetts. And so trying to understand the complexity between severe behavioral health episodes, some of those kids cross over into severe medical conditions as well. And so understanding that is an interesting space for us. And then the final thing I'll mention is just that Children's is a referral hospital. So our integrated network is really only a subset of our patients at the hospital. So trying to balance the understanding of activities that need to take place at the hospital for everyone and understanding how our clinical network can improve while touching that entity is a real challenge, and one that we've embraced at trying to fix or trying to work on. I wouldn't say fix, but try to really improve the mechanisms for all kids, not just for our own network.
Wonderful. Thank you so much. Dr. Lee, you had made the comment to me that there are a lot of different sources of data, of course, as we know, and clinical people tend to think of the clinical data as the most important. Revenue cycle management people, for example, will think of claims data, but really the most important data is the data that can be married and combined and really used and analyzed. Tell me some of your thoughts about that, about how you had said that the US healthcare system overall is not as far along on the journey as we sometimes think we are in terms of looking at outcomes and also marrying the clinical and claims data to understand where patients are.
Yeah, and before I took this role, I was the senior director of informatics at a large healthcare organization in Boston, and worked for 10 years on EHR adoption and patient portals and all the apps and things like that people use. And really, my belief is that whatever data sources we have, the real goal of aggregating them is to use them in a way that we can change the clinical performance on the front end. So we either have to get information in the hands of the end users as providers, we have to be able to share information with patients, and certainly in the pediatric world and in the adult world. But Alex mentioned earlier about interfacing with schools. Trying to figure out how you get data from devices, other types of things like that are all in play right now. And I think making this a really, really interesting time. I think that in our network, one of the great challenges is that our primary care network is on an Epic instance. Our hospital is actually on a mixed EHR instance. We have Epic for scheduling and billing, and we have Cerner for our clinicals. And then we're bringing in claims from multiple payers. And so trying to figure out which data you need and how to park it in the right place and to really inform clinical activity is an incredible challenge. And I think that if you look even at the struggles we've had in Massachusetts for provider identification, Massachusetts Medicaid uses a separate mnemonic called a PIDSL, Provider Identification Service Location, which is a blend of practice location and provider ID, as opposed to an NPI, which is the National Provider Identification, which is standardized. So right away, you create mapping issues. And the same is true on patient identification. I'm sure Alex can comment on that too, but trying to identify patients across systems and locations. And our children receive care. There are 5 different pediatric institutions in Massachusetts. We're not the only one. And because we're so widespread geographically, our children receive care at all of those institutions too. So trying to figure out care that's taking place outside of our institution is as much of a challenge as inside.
Absolutely. And I know you face that at Nemours also, Alex. What are some of the complexities that your team is working through? Oh, Alex, I knew that you muted yourself. You silenced yourself. Go ahead now.
I did. So a lot of the same challenges. I mean, I think one of the things you'll find in healthcare, particularly in PEDS, I mean, you get 5 of us in the room. We're going to tell 5 versions of pretty much the same story around some of these things. We are running into a lot of issues with matching, with common identifiers not being used by payers. For example, he gave the example of the Medicaid provider ID. That's a big one. Why would we ever get a report from a payer that doesn't have an MPI on it, that has their own proprietary ID? What exactly is an expectation we would do with that when there is an identifier that we can all share, right? Deduplication of patients is a big one that we're running into a lot lately, particularly with our clinically integrated network, where we find we create a patient record And then the source organization makes an update to the demographics. And then we get that patient in a panel the following month. And, you know, sometimes the updates the system handles as innocuous and says this is the same child, but there's rules in every matching algorithm that says this simply is not, we can't verify it's the same. And so we end up creating these giant queues and work lists for our HIM department or our EMR support teams to address that just add noise to a process. It's, you know, or if to say, well, the data is right now 95% complete, you know, things like that. So those are challenges. I think we're learning a lot through it, and I think the technology has gotten a lot better. Often it's who handles the errors or who handles what it recognizes that needs to be fixed. So it really moves into the process kind of realm.
Yeah. Dr. Lee, do you have any thoughts about what Alex just said?
You know, I think that the interoperability challenges really we all face those, and I think that you know, patients move insurers and they move providers, and so making sure you have the right package of data, you know, especially in the public realm where people drop on and off of Medicaid, as an example, there are real gaps. And I think the other piece is the difference between clinical data and the lag of time on claims and administrative data is also very significant in this space, in trying to really understand what's happening with a pattern of space. I think that, you know, adding in other sources like health-related social needs, and I'm very interested in the race, ethnicity, language data. You know, one of the things we're just testing right now is I'm curious on the same patient if our primary care network and our hospital network, when patients cross, actually have the same information for what are supposed to be standardized categories. And, you know, patients age, right? Their parents may or may not be together. How those people answer questions about their race and ethnicity could be incredibly divergent. And as kids become adolescents, they may differ on how they see themselves, and how and what groups they feel that they belong to culturally and things like that. So I think it's going to be a really interesting time for learning how impactful this data is.
Absolutely. And I'll just say purely on the demographic front, more and more Americans are multiracial. They're defining themselves as such, but there's no consistent way to count them. There are still systems that only allow you to be one race. In the next 20 years, we'll have up to a quarter of people in this country will be more than one race. So we need to get our act together on that, just purely on the counting side, right? So that we're not messing that up. Both of you, I'd love to know your thoughts and perspectives on the particular complexities of doing this kind of analytics work in the pediatric space. What makes pediatric care-based analytics different? And whoever would like to begin, and then the other can speak first.
Sure. I don't think right out of the gate, I think the analytics are different. I do think the problems you're trying to solve are very, very different. So as an example, you know, the primary sources of cost reduction, as a perfect example in adults, are to reduce hospitalization at the end of life, right? And reduce procedures effectively later in life, and make sure that chronic diseases are managed appropriately to reduce hospitalization, like diabetes, obesity, cigarette smoking, heart disease, hyperlipidemia, right? There's a subset of them which can be fairly well protocoled in terms of understanding what goes on there. In children, we have a similar kind of percentage of high cost patients in our networks, just like adults do, but their life courses are incredibly diverse from there. They have multiple different complex diseases. They require a fair bit of specialty intervention in order to manage those diseases. And we expect them to survive, thankfully, through the whole of their child life, which is not the case with adults, sadly. But when they get very, very sick, there's a path there which is leading to death within whatever 5 to 10 years, and so trying to manage those things are very, very different. I think that Two other issues that are critical are the number of inputs where you're guaranteed to have parent inputs. As I mentioned earlier, they may not be together, the parents. And then adolescent confidentiality. I think that the information blocking rules and the new work on confidentiality can in some circumstances even interrupt care further because we want to be limited in how much adolescent information is shared broadly, but not sharing that information can really impact the care of those kids as they move through a system. So I think there's a few areas there that are really kind of funky. Last one, I won't kill all your time, Alex. The last one is the newborn period, where kids often don't have names when they're identified. And we even struggle with Brigham and Women's and our hospitals share physical space and share mothers and patients. So we have prenatal and postnatal care. And that is an enormous challenge from an information perspective to manage the parent, the fetus, the child during that period of pregnancy and post-delivery. So really challenging information issues. Alex?
You remind me of a story from someone coming to me and saying, Alex, do you realize we have a bunch of pregnant 6-month-old babies? And it actually is about that, just the documentation of parent and child information. It was a process issue, but data reveals everything about workflow. That's one of my common sayings. So other differences, I love where he mentioned the difference in the adult and the children. So the biggest sources of healthcare spend for children are kids who sadly have cancer, are NICU babies, are transplant kids. They're not preventable, right? So we end up, we're trying to lower the height. If the height is healthcare spend by trimming the haircut. Cutting hair shorter to say, oh, we cut spend, but basically discharging kids a little bit earlier, reducing a standardization of some OR tools or things like that. The biggest gift that pediatrics can give to the taxpayer or to the state budget is healthy, functional adults. But those don't live in our realm. So where we can most impact economically is an area that's outside of our contract cycle. It's outside of our ROI calculation typically, and it's outside of our even just our whole finance model. And yet the ROI on what we do and what we invest in is magnificently greater, orders of magnitude, when we think about, do I have a healthy potential tax-paying, potential non-service consuming adult that emerged because of something that a health system, a pediatric health system, was able to influence or do, and that's something we need to get to. In terms of other just simple mechanical things, a lot of the models, because most of the healthcare investment goes to adults, a lot of the technology investment, the predictive models, the systems, the analytics, they're designed for adults, and so we kind of end up sitting in the back of the room going, okay, they've gone through 10 items here. Maybe the 11th one will work for us too. And every pediatric health system goes through that on the technology side. The other thing we run into is also, this is a good thing, but it is a problem. Our ends are much smaller. And so here we are, we're a health system, we have 2 hospitals. Our 2 hospitals glued together are one wing of one adult hospital, right? And so in size, and so when we start to look at data, and there's some amazing data sharing collaboratives for pediatrics out there, but it does make it difficult where people want to look at ROI, they want to look at effectiveness, and they want to study things. Often the low end makes it difficult, or if you're looking at adverse events and things like that, then just trending and things like that get a little more complicated for us. And I think for our major adult systems where they have the benefit of huge populations.
Absolutely.
Well, we've tried to look at bundled payment as an example. And, you may have ear tubes and appendectomy that are big enough from a surgical perspective to look at procedurally. And we've done some great work improving the quality and performance on those 2 items, but there are hundreds and hundreds of surgeries that are done for so many different reasons that we don't have big enough populations to really assess what appropriate payment or hospitalization might look like in those. Really challenging analytic area for us.
Yeah, absolutely. And Alex, you had told me that sometimes statements are made about problems as being the data, when in fact they're structural and prioritization issues. Can you talk a little bit about that as someone who is over a team of analysts?
So I don't want to make it sound like we don't have some of the problems. Obviously, when one source of data hyphenates it, puts an apostrophe in a name, and another doesn't, and you end up with patient mismatches, we do end up with those quality issues, date of birth errors, whatever. But the reality is we have magnificent technology right now. Anybody who remembers what we thought of, like what Meaningful Use said we'd be able to do back in the early days, and then looks at what we're able to do now, knows that it's science fiction compared to what we could do, not too many years ago. And so it's, when we think about, I have to standardize process, I have to standardize input, I have to talk and get doctors to do things the same way. Just capture of demographics, right? So let's take that example. So we know we have an issue, you could call it a data problem. We don't have a standard model of looking at biracial children, right? Okay, that's a data problem, you could say. But the reality is, it's a process issue. We have to standardize workflow, standardize input at a time when the idea for me to go, if this were my issue, to go to an administrator or a nurse manager or a physician leader and say, I need you to ask your doctors to do this, or I need to ask your red staff to do this one more thing a certain way. And we need to get the energy to do that with our neighboring health systems. That could be the straw that breaks the camel's back in terms of the ask, because it's really about process and standardization and adding friction to workflow. And of course, a vendor is going to hear this and call and say, we have a model that will make it all seamless, and yet that's also friction, and that's also adding more. And so even dealing with payers, it's like, why can't we just address some of the basic conversations around their reality and our reality to prevent those data issues? That systems are magnificent. They're flexible. They can handle so much. They can match now. They can do fuzzy logic. They can do all, but we can't get someone to update a list of doctors who are employed somewhere, and they keep giving you a list of people who termed 5 years ago. That's not a data problem. That's a workflow, and that's understanding the importance of updates. It's process. It's an Outlook reminder saying, remember to update the list of termed doctors.
And what are the key things that payers can do right now, both of you? But go ahead, Alex, since you brought that up. Simple things.
Simple things would be, we need common keys and common labels and common formats. So in the United States, we know we don't have a single payer model, and there's reasons why, but we could benefit, and we could really help realize some of the promise of cost reduction if we could get more standardization. So all quality reporting could have maybe the same standard, and the way that we've managed to standardize formats for interoperability elsewhere in healthcare, if we could get some standard reporting formats. The example about the physician MPI that both of us have horror stories on, that's a big one. Like, please don't ever send me a list of doctors without an MPI on it. Literally just, that should never exist. Yeah.
It's meaningless for you.
It is. It's a classic example. I just got a diabetes, where they're changing a prior authorization process on continuous glucose monitoring for diabetes. And they sent me a list of patients who would be affected by this change, and had doctors' names but not the locations of where the doctors practice. So I don't know if they're Boston Children's doctors, they're Boston Children's ACO patients. So how am I going to impact that, from using that kind of report? But it gives an example of just not understanding so much the clinical workflow. I spend a lot of time trying to resolve authorization related issues. That's an administrative barrier that seems to be growing by the minute. It's actually disabling our hospital. We have now multiple FTEs in every single department in our hospital just doing authorizations. That's all their job is. And the number of appeals, denials, technical things, there's an entire industry now of new software companies trying to beat that wall down, which is just another overhead layer, right? I understand, it's great. I'm glad they're getting in there and they're going to fix it. But if you ask my institution to pay for it, yeah, so it's another 1% on the overhead of trying to do IT things. And they wonder why IT costs so much. It's a sad state of affairs that we can't manage some of that. We just ran a report on COVID vaccines in our network. One of our major payers came out with only 6 children vaccinated, because it turns out that because those codes don't pay in Massachusetts, they didn't include that code in their report, right? So you have to figure it out a different way. And it's just funny, there isn't a way to do stuff easily. And I think that's what Alex is getting at. There's some ways to reduce friction here in the system that people are just not being thoughtful about. And the same is true on quality reporting, which our state is trying. We've gotten to kind of a uniform agreement on the major HEDIS measures and how they can be reported, so that will be common. But that's a pretty low bar if you're really trying to improve care in your network to just get HEDIS measures. It's just not enough to know what's happening. So I think that's key.
Yeah.
If I could.
Oh, go ahead, please, Alex.
Well, I just along this line, and I know it might move the agenda a little bit in a weird direction, but I think it would be lovely if we could get some kind of cooperative of payers to say, teach us about friction. And what does it mean that I now have to invent a roster management specialist concept as a role that I need because I need it, and go and ask for money? And what does it mean to us when we hear a payer has a new program, a new portal, a new tracking mechanism for SDOH, and all of those things seem like they should be wonderful, but I'm assuming this is true for Dr. Lee as well, if they fill me with terror, because it means now that I have to accommodate variation, and I have to accommodate passwords and logins and training and manage staff when they leave, and now I have to have one way to do things, except a different way for payer ABC, because they want it done this way because they have a new system in place. And I think those are the things that introduce that friction. Whereas if we could just say, okay, insurance company, you're going to deal with this, where they're trying to transform. I've seen some people that are enormously mission oriented. I'm not cynical. They really are trying to do the right thing. But let's say this is your realm and this is our realm, or these are the systems you're going to manage. We need stuff that we can use for all payers, so you all don't buy and build any of it. But we need you all to work on these things because we don't have the skills and expertise. And if we could do that, I genuinely think there's definitely millions and millions of dollars that could be saved from the health system if we could just align a little bit.
What should be done on the policy level? What's if both of you could give me a sense of what can be done simply by reaching out to your payers versus where you think federal healthcare IT policy needs to change. Where's the line there?
Yeah, it's a huge challenge. I certainly testified personally at some of the meaningful use stuff, which, I'm a huge supporter of EHRs, and I am thrilled that we are a country filled with EHRs, which we were not until all that legislation came through. And so, which is great, but it's not enough, right? It's a base. It's not sufficient. I think the efforts right now on interoperability are really helpful. I think that they've actually made some steps forward there. I think that part of what Alex said is true. I think it will take policy level activity to get the insurers to standardize in a way. And they have an ability to scoot around standardization, that this part of the file is standardized, but this part of the file is custom, and that's too bad. So I think that that's an area of things. I certainly would love to see federal patient identification. I think that was a slam dunk 20 years ago and has never been able to find its way through Congress. And that's a simple thing that other countries have done forever that we don't do, that I think is and again, it won't help us with newborns. It won't help us with people who are here illegally who still require care. There are things it won't help us with right out of the gate, but boy, could it fix 90% of a lot of things. And I think that those would be opportunities. There's a bunch of systemic issues around maintenance and access of insurance and health savings accounts and other kinds of things that you see in other countries. Singapore is a good example of where people have been able to stabilize the insurance for their lifetime rather than the fluctuations. And there's a whole bunch of things that affect care greatly that I think we could do without being a single payer. And I grew up in Montreal. I'm well exposed to single payer healthcare. I'm actually not a huge supporter because there's budgeting and restrictions that come in other areas with single payer healthcare, and that I think we get around in this country. But I do think we've made it too hard for ourselves, and I think that those things would make a difference.
What's interesting to me is that, we had a panel on interoperability and we talked about TEFCA, but that's only about how data is moved around, not what kinds of data you need. So it's like we have so many layers that we have to address. Alex, you probably have thoughts about what Dr. Lee just shared.
Oh, I agree on the patient identification would be huge. It's one of those things. It's like we're spending millions of dollars deciding how to tunnel and create standard tunnels to get into houses. And someone's going to say, why don't you use front doors? And we're like, oh, we can't. Right? It's as simple as that, right?
Yeah.
And so that is one. Another one that I'm a big fan of is really standard economic models that we can look at, that even if it's not really like legislatively dictated, the government could issue kind of best practice to measure the effectiveness of what I mentioned. The effectiveness of what we do is, as we're all focusing more on population health and well-being, we know where we're going to have the biggest impact, or where we have the potential to have the biggest impact. How do we get a standard calculator that everybody can go to Medicaid with, to their own state Medicaid agencies or to payers, and say, well, this is the return of this model. We actually supported, 0.5% increase in graduation rates. Okay, that doesn't seem like much because we took chronically ill kids that before struggled with schooling and now they're more successful. Let's pretend that's the case.
Yeah.
Well, that actually results in a 10-year ROI of X amount of money to the state. And if we had some standard models, I think it really would help explain, and justify investment. So investment in some of these programs that fall outside of our managed care contract annual cycle really has its own independent financial validation separate from just keeping to a mission.
Yeah.
It's kind of a strange thing. And so I think that would help. Ann Milgram gave a great presentation at one of the conferences where she talked about what happened when they saw the correlation between high healthcare utilizers and high criminal justice utilizers. It was two data sets that lived independent. When they linked together, they found the overlap was so tremendous that if they intervened in the healthcare side, they could actually save a huge amount of money on the other end. Yeah. And it's like, well, there you go. That's money better spent because we were able to really, an economic model was able to be developed. And I'd really love to see that in the PED space in a way that is common, and then we can go, and I can go and sit with Dr. Leake and say, hey, this is what we learned. And we can say, cool, we're going to steal that, because we now understand ROI in a way that is kind of compatible, that we can take to our state, for example. So that would be something I think that policymakers could really assist with their clout, and also with the expertise that the government has at looking at those different sources of expenditures.
Wonderful, wonderful. Well, lest we be accused of being Debbie Downers, I'm going to ask each of you just share one discrete area where you've made a nice advance and you'd like to just share that with our audience. Dr. Lee, why don't you go first?
Sure. There are so many things that we've tried and that I think have really worked in the standard health system that I'm very, very proud of. I think One of the experiments that we've done with our Mass Health ACO that has been supported by Mass Medicaid is the flexible services component, where they have allowed us to take funding that is 100% not geared to pay for anything within our health system, and we use that funding to support food needs, food insecurity, and housing insecurity in our network. And we have been able to look at both the cost of those services, and that includes tying referral to community agencies that support these things. So we're not building systems that supply food and housing for patients, and trying to tie that to activities. And so we're tracking with our analytics how much it's costing to deliver those services, which are fairly expensive. It's between $5,000 and $10,000 per patient who is housing insecure, to either stabilize their housing or replace them. And those are the kinds of numbers that should tell you that if we could actually, as a more globally, provide safe housing for these families, we would be in a better position, because the amount of trauma-induced events that occur for those kids who are out of safe housing is fairly significant. Never mind other things. I think that area is one that I'm most proud of for my team, to have built some of those interventions, and very proud of Mass Health for being willing to support those types of activities in our state.
Wonderful. Alex.
So I'm very excited about the disparities work we're kicking off. I'm very proud of it. I love where we're starting, which is looking at some very basic things like just access to care and no-show rates, not yet even focusing as heavily on some of the clinical outcomes, but the fundamentals. And then let's see where that leads us down a path to closing some of those gaps and advancing equity. I'm really thrilled with the work we're doing around social determinants right now, which it's hard. It's hard to, for example, gather information, to introduce something new into clinic workflows, but it produces those interoperable Z codes, even if they're not perfect. And once we can combine that with some great geoanalytics and other sources of social determinant information, which is on our roadmap for the next 6 months or so, I really think that the missing pieces of a lot of models will start to emerge, like better readmissions predictors and better outcome predictors, because we've been operating with one eye closed, or I don't know, you could come up with many analogies for so long, and now we'll finally be able to fill into the gaps of what's actually driving health and outcomes beyond just the purely clinical.
Yeah, I think that's wonderful, and both of your teams, I know you're making progress in those areas. That's absolutely fabulous. What do you think how will your world look a few years from now? And when I say your world, I mean, again, data analytics for population health management and care management and related areas. How will things be different 2 or 3 years from now?
Yeah, I think for me, what I'm most excited about from the analytics side right now is kind of understanding this journey of remote access to health services better. So whether that will be remote applications, telehealth, or other things that intervene, school health that Alex mentioned. I am very interested in seeing how we can incorporate care, what I always called between visit care in my old job, but really understanding that people only intersect with our healthcare system for a very small fraction of their existence, except in that newborn period or when they're really, really sick, as Alex mentioned, and trying to really get their home life, be able to support them so they don't have to interact with our system as much, and really understanding that from a data point of view so that we can really make sense of what is valuable there, I think is a really exciting part of our work moving forward. And that's something I'm very excited about paying attention to.
Wonderful. Wonderful. Alex, your thoughts a few years from now?
a few years from now, we'll not only be looking at our populations in terms of those clinical flags, but and some systems are already going down this journey now, but some of the social factors, the disparity and equity factors will have much more integration of genomic information as we look at predispositions in our systems to say, this is what we need to do now early. And that's exciting to think about where that'll take us. And then to the point that was just made, we'll be thinking about care much more broadly. We'll be thinking about outreach and communication with patients and families in different ways that we do. And we won't keep talking about so many of the things that are separate things now as separate. We talk about telehealth as a separate thing. We talk about looking at equity and disparities as a separate thing. We talk about just all this compartmentalization, and the reality is it'll all just be care.
Yeah.
And it'll all be well-being, and that's where we need to go.
Well, I absolutely agree with that. Finally, gentlemen, can you leave our audience with one good piece of advice as both of your organizations, I sense, are rather advanced based on what you shared with me. There are many organizations that are not as far along as either of yours. One piece of advice as they tackle this gigantic ocean called analytics for performance improvement and care management. Alex, why don't you go first, and we'll have Dr. Lee. Just one general piece of advice that might help our audience.
I would say don't underestimate the impact that having your data analysts who support like outreach efforts or pop health efforts, having them trained a little bit more in operational workflow to help workflow oversight. Just little things like for us, like, yes, we can monitor how many COVID tests we did, but with a little bit more awareness, we're also able to spot where we're coding them wrong to bill, or we could do, we noticed where doctors were resulting them in the wrong space or whoever was in the wrong space in the EMR with just a little bit more education. So that ability to support workflow analysis in addition to just kind of overall volume reporting when new processes are introduced, I think is one that it's really proven to be a big win for us. Wonderful. Dr. Lee?
That's a great, I think that's a great advice. Ours, I would say a little bit different, learn from my own experience, which is make sure that you know what problems you're trying to solve before you try to build the data solutions to support them. I felt like I walked into my role and there was a massive data project underway that had no real connection to what was actually going to be offered by the network in terms of clinical ideas. And you can make a lot of data work without a lot of value if you do it that way. So I always say, find the business problem first, then work with your IT folks to solve the business problem together rather than doing them separately that way.
Yeah, it's a little bit like if you walk into any hospital in this country, I'll certainly accept your systems, make exceptions for you, but you could ask a nurse, a floor nurse, why is such and such done such and such way? And that nurse will say, well, no one really knows. It just happened that way. And so, someone in 1781 decided to do it that way, and we've been doing it that way ever since. So I think you're right. Absolutely. Find the business problem, find the strategic organizational issue that you really want to focus on and direct your energies, because no one has unlimited resources, right?
Exactly.
Well, thank you both so much. This has been absolutely fabulous. Alex Koster from Nemours Children's Health and Dr. Michael Lee from Boston Children's. You've given us great insights here. I've learned a great deal. I'm sure our audience will have learned a great deal too. I want to wish you the best in all of your work. I can tell you absolutely are advanced organizations and that you're showing leadership and really moving your organizations forward. So congratulations and best wishes on that. And again, thank you for being with us today. We really appreciate it.
Thank you. Thank you, Mark and Alex, very much.
Thank you all.
Thank you very much. Have a great rest of your day, everyone. This concludes this session for now. A great day to everyone. Thank you.
Take care.
Beautiful. Thanks.